Welcome everybody to the January webinar for the Midwest Vascular New Horizons. We have some great panelists tonight who will be speaking on advances in deep venous disease treatment. I want to offer everyone the opportunity to put any questions in the Q&A box as we go along. We'll plan on having all four speakers present their topics and then doing Q&A at the end. I'm Mike Malinowski, vascular surgeon at Medical College of Wisconsin. I'm joined by my co-moderator, Trisha Bobrowski, vascular surgeon from University of Chicago and the program director of the Vascular Surgery Fellowship. Our talks tonight will be by Dr. Simon Fraser, Matthew Smeds, Lauren Masterson, and Chelsea Dorsey. We'd like to give a thanks to enVVeno Medical for support and sponsorship for this webinar to allow us to look into new treatment options for deep venous disease and a really tough pathology and clinical population to treat effectively. And with that, we'll start with our first speaker tonight. Simon Fraser is a vascular surgeon from Ohio Health Doctors Hospital and Riverside Hospital. He's an associate program director of Ohio Health Doctors Hospital General Surgery Residency. He completed his vascular surgery fellowship at the Medical College of Wisconsin in 2022, and he will be talking on non-operative treatments for deep venous reflux. Simon.
Good evening, and thank you for the opportunity to be able to present. And thanks for the New Horizon Committee for allowing me this opportunity here. So I had the honor of being able to discuss non-operative treatment for deep venous reflux. I have no disclosures other than limited experience and not an expert at all in this, but definitely took the opportunity to be able to learn more about this topic through this lit research here. So we're going to be talking about venous insufficiency and varicose veins and non-operative management here. Looking at the prevalence of the disease, it's one of the chronic venous disease is one of the most common chronic diseases in Western Europe and the United States. It affects more than 25 million adults in the United States alone, and 6 million of these have advanced stages of venous disease. And more than 20,000 patients are newly diagnosed each year in the United States. Looking at the socioeconomic impact of this, roughly 10.4% of patients miss days of work as a result of the symptoms of this disease process, as well as miss work hours and medical disability. Patients with this disease are also further burdened with chronic treatment and wound care expenses that can amount up to almost $2,400 a month without even surgical intervention. The mean length of disability-related chronic venous disease has been estimated to be up to 38.7 days per year, which amounts to about 2 million work days missed each year in the United States. And 1 in every 8 of these patients retires early secondary to chronic venous disease-related symptoms. In the United States, the collective healthcare burden of this disease process is estimated to be upward of almost $3 billion a year, which accounts for about 1 to 2% of our national budget, and more than $1 billion being spent on wound care expenses alone. We're all familiar with our classification system here, and this is just a little slide to give you a little bit of a refresher. When we look at our risk factors here, there's a significant amount of non-modifiable as well as some modifiable risk factors, specifically age, female gender, height, number of pregnancies, prior DVTs or trauma, history or genetic component, and jobs that require prolonged sitting or standing. Modifiable include obesity, low bioimpedance, sedentary lifestyle, and smoking. And when you look at functional venous insufficiency and venous hypertension, this is caused by obstruction of venous return, which can be elevated secondary to central venous pressures such as obesity, obstructive sleep apnea, right heart failure, lymphatic dysfunction, or decreased forward momentum of blood flow from poor calf and foot pump function. And so the majority of us, when we graduate fellowship, understand that compression is the answer. but obviously there's more to this than just compression. When we look at lifestyle modification, there's a number of things that come up. Exercise is a big component. As I mentioned earlier, foot pump is a big component to this, and contraction of the calf muscles by foot flexion and extension plays a critical role in venous return. In single contraction, ejects about 100 to 150 milliliters of venous blood and reduces the venous pressure by about approximately 25 millimeters of mercury. In 2019, there was a study that was done that looked at the immediate impact of physical activity on venous return in 61 patients. And this data demonstrated that there were significant changes in reflex duration and volume with respect to rate, 4.85 seconds and 17 milliliters before exercise, down to 2.86 seconds and 10 milliliters after exercise. Leg elevation also shows to be an aid in venous drainage and venous return, and it is advised that patients elevate their legs about 30 centimeters above the heart several times per day. In a retrospective review of 122 patients with previous venous ulcers, they followed for 12 to 40 months, and they found that significant lower rates of recurrence were associated with those who complied with compression therapy and longer elevation times to a day, roughly 33 minutes per day, versus recurrence occurring in patients who only adhered to about 14 minutes per day. In lifestyle modification, looking at weight loss and data from the Bond Vein study, this showed that patients with BMIs from ranges of 25 to 29.9, 30 to 40, and greater than 40 had odds ratio risk of disease progression of about 2.26, 2.86, and 3.47 respectively, compared to patients with normal BMI. There's also a number of drugs that also lead to leg edema, and as you can see here, there's things that you can definitely look at that patients are chronically taking that could potentially be modified to help with their edema. Some pharmacologic therapies that people have looked at along the line to help with venous insufficiency have been diuretics. And these have only been seen to be benefit in those with congestive heart failure. Zinc has a theoretical benefit to play a role in the venous wall, pathophysiology and cell proliferation. Fibrinolytic agents have been looked at but have seen no benefit in ulcer healing. The big one that has really shown much benefit has been the flavonoids. And there's been studies that have shown that the MVSS results in reduction of leukocyte adhesion, migration, as well as inhibition of the production of inflammatory molecules that cause damage to the endothelium and subsequently increase capillary permeability. And in 2016, this was confirmed by a study that showed the uses of MVSS medical therapy alone or adjunctive to compression therapy had beneficial outcomes without serious side effects for patients with chronic venous disease. But we really want to look at the cornerstone of what we're talking about here, and that's compression therapy. So some contraindications when we talk about patients with compression therapy: acute cellulitis, wound infections, PAD with patients who have ABIs of 0.5 or less, severe peripheral neuropathy, contact dermatitis or allergies, compartment syndrome, severe congestive heart failure. The cornerstone of compression therapy have been the gradient elastic stockings, and these come of a number of different classes, ranging from 10 to 50 millimeters of mercury up to 40 to 50 millimeters of mercury. The pressure applied is proportional to the stiffness of the wrap, which is determined according to the radius of the limb, number of layers, and the inherent properties of the wrap, including the elasticity of the material. There's a number of different types: long stretch versus short stretch, with long stretch tightening while resting and stretching while being applied under pressure or working, and short stretch, which is low resting pressure but high working pressures, which is preferred for multi-layer compression for swelling. And as you can see, here's just a little diagram of how compression improves venous flow. improves lymphatic flow, and increased volume and rates of venous blood flow owing to the improved efficiency of skeletal muscle pump and reduction of vein diameter, reduced venous reflux, reducing the edema and inflammation, and has also improved microcirculation and cutaneous oxygenation. And when you look at the different types of compression, we have different measurements that we look at for the different severity of the disease process here. Other adjuncts outside of gradient compression include SERP-A garments, which are non-elastic compression appliances with multiple stiff, pliable Velcro bands. The system is as effective as gradient compression stockings in reducing edema and promoting the venous pump function. It's recommended for patients who are unable or unwilling to wear class 3 stockings, and it's recommended for patients with C4 or C6 disease. The Una boot, which was developed by German dermatologist Paul Gerson Una, it's consistent of a multi-layer compression dressing made of an inner layer of gauze bandage impregnated with calamine, zinc oxide, glycerin, sorbitol, gelatin, magnesium aluminum oxide, and an outer layer of elastic wrap exerted in a graded compression. This is changed weekly, and the bandage stiffens as it dries, which helps improve the venous return during ambulation and reduction of edema. It is recommended for patients with C6 disease. Looking at a 15-year retrospective survey of 900, almost 1,000 patients with venous ulcers, the Una boot achieved almost 91% healing rate for the first-time ulcers and an overall 73% healing rate in compliant patients. Looking at layered elastic and non-elastic compression bandages, there's a number of different brands out there. So you have your single layered dressings, long stretch, which is our basic ACE bandages, medium stretch, which is a great option for compliant patients with edema who do not want to use multi-layer dressings. It's more economical, and it's an option for maintenance after ulcer healing. And then short stretch, which can be applied up to 30 to 40 millimeters of mercury. It's capable. It's great in capable patients who are able to train frequently. It's reusable. It's economic. It's not useful for controlling severe edema, and it's ineffective in non-ambulatory patients. And then we have the multi-layer dressings, the 4 and 2 layer dressings. Other devices include the intermittent pneumatic compressions, which is a mechanical compression method which exerts an external pressure that does in serial fashion up the leg from foot to thigh. There was a Cochrane review that looked at 7 randomized trials. In one trial, IPC was found to be more beneficial than compression stockings in ulcer healing. 4 trials compared pneumatic compression plus compression, in which only one of those 4 trials showed increased ulcer healing, and the remaining 3 trials showed no evidence of any benefit to intermittent pneumatic pressure. So when we look at all the different choices, it can be pretty difficult to decide what to do next. But thank goodness we have a couple of guidelines that we can follow here. So from a consortium from the International Angiology Society, looking at kind of recommendations here. So for patients who, when we're looking at uses for light compression stockings, they recommend the improvement in symptoms of heaviness, so our C0, C1, and varicose veins in pregnancy, prevention of leg swelling related to prolonged sitting and standing, as well as our post-operative patients for preventative of VTE. Compression stockings, 20 to 30 millimeters of mercury, is great for sclerotherapy after for small telangiectasis, and improvement in subjective symptoms of varicose veins of pregnancy, treatment of DVT, and for treatment of venous edema and venous ulcers. Compression stockings, 30 to 40 millimeters of mercury. It reduces dermatosclerosis areas and heal venous ulcers, reduce the recurrence rates of venous ulcers after healing for C5 disease, or higher pressure, and higher pressures seem to be superior than lower pressures. Compression bandages are great for those with venous ulcers, grade C6, acute DVT, and 4-layer bandages are better than 2-layer bandages. And intermittent pneumatic compression level of evidence for ulcer healing is also weak, but it's adequate for patients with post-thrombotic syndrome. Looking at the guidelines from the Society for Vascular Surgery, as well as the American Venous Forum from 2011, their recommendations are for patients with venous ulcers grade C6. They recommend compression therapy over no compression therapy to increase wound healing. Patients with healed ulcers are recommended to comply with compression therapy to decrease the risk of recurrence. Multi-component compression bandages are recommended over single-component compression bandages. Patients with venous leg ulcer and arterial disease, we do not recommend compression bandaging for ABIs of less than 0.5 or an absolute ankle pressure that is less than 60 millimeters of mercury. They suggest the use of intermittent pneumatic compression when other compression options are not available, cannot be used or have failed to aid the venous leg ulcer healing after prolonged compression therapy. As I said earlier, I'm not an expert in this field at all, but I am blessed to be able to work at Ohio Health, where I get to collaborate with many great physicians, including Dr. Raghu Kalori, who is the director of our vascular medicine department, and many of you have maybe crossed paths with him at our international collaboration societies and Viva, etc. But he was able to provide me with some of his more successful cases here and some of his patients I just wanted to share with you here. First here, we have a 71-year-old male who had normal ABIs and negative venous insufficiency duplex and diagnosed with lymphedema. He was on the left here, you can see this is the pre-therapy picture here. He was started on Circade wraps and then lymphopress compression pump, and here is his most recent pictures here with almost significant improvement in his varicose veins as well as the swelling. Good example of what compression therapy can do. Yet beware, here's an example of what not to do. Unfortunately, this patient purchased compression bandages over the internet that were too high grade and ended up misusing them and developed a significant wound to his leg here and wasn't under the guidance of any therapy. Came to the office and is now currently being managed with wound care and debridement, and hopefully be able to heal these ulcers. I'd like to thank the Society again for allowing me to participate in tonight's webinar. Congratulations to The Ohio State University on their national championship this year, and I look forward to discussing this further at the end of the case. Here are my references.
Great. Thanks so much, Simon. A really comprehensive review of non-operative treatments. Our next speaker is Dr. Matthew Smeds. Matt is a professor of surgery at St. Louis University. He's the former program director and chief, and he currently serves as editor-in-chief of the JVS CIT journal. He is going to speak to us today about how to select patients for venous valve reconstruction. In the meantime, I encourage everybody, please put any questions you have in the chat, and we will share them at the end with our speakers. Matt, you're on mute.
Sorry about that. My computer minimized my screen and I couldn't find it all of a sudden. You can hear me now? And you can see my screen okay?
Yes, we can.
Great. So I'm Matt Smeds. Thank you for the opportunity to speak with you all tonight about the novel bioprosthetic veno valve and how to select patients for its implant. A couple of disclosures. I am the site principal investigator for the SAVI study, and enVVeno has provided some grant support for an annual cadaver exposure course we have here at SLU every year. They've also provided me some of the data I'll be presenting regarding the device and its outcomes in the pivotal trial. You're all familiar with chronic venous insufficiency. The disease process affects over 2 million individuals in the United States, and has a profound impact on patients' direct medical costs and quality of life. Patients suffering from this illness often report incapacitating leg swelling and pain, resulting in missed days of work and high rates of ulcers that are often recurrent. The standard of care, like Simon was just talking about, is in the treatment of chronic venous insufficiency is supportive with compression therapy. Some procedures are done to optimize venous outflow, such as the iliac vein stents, or to treat coexisting superficial venous disease, such as saphenous vein ablation. But there really are no standard surgical vascular reconstructive techniques to treat the underlying valvular incompetence that is present in these patients. Described techniques have been inconsistent, outcomes are not reported in significant numbers, and for the most part, these procedures are limited to a few centers worldwide. To this point, there have been no standard prosthetic valves available. The Veno valve was created as a novel surgical approach for patients with incompetent deep veins. It's a glutaraldehyde cross-linked monocusp porcine aortic valve with a section of aorta in a rigid stainless steel frame. It comes in two sizes, 9 or 10 millimeter diameters, both with a length of 21 millimeters. The device has a 3 millimeter sinus protrusion, which acts as a flow regulator and also reduces stress on the valve leaflets. The role of this sinus and venous valve function has been previously studied, and it was an important addition to the design of this device. Native veins are dilated at the valve region, which creates a sinus pocket similar to this sinus pocket in the device. And the role of this pocket has been studied in flow dynamic models using particle image velocimetry. It's been shown that the sinus smooths flow patterns and helps maintain a vortex structure during the valve cycle with lower vorticity or fluid rotation. The sinus also creates a forward flow near the wall, resulting in weaker shear stresses and the maintenance of a vortical structure. In aortic valve systems, the sinus pocket on these valves is known to play a positive role in reducing solid stress to the valve leaflet. The Veno valve device itself went through extensive preclinical bench testing prior to implantation. This includes a dye injection test, which revealed complete washout without zones of stagnation. Particle image velocimetry, which showed undisturbed parallel flow with a maximum peak velocity of 1.4 meters per second, and accelerated wage testing, which has demonstrated valve competence and integrity through over 100 million cycles and 5 years of testing. Hydrodynamic evaluation was also performed with simulated conditions, including changes in cardiac output, beat rates, and pressure differences estimated at several different conditions, including at rest or walking. Because of this extensive testing and data from the first-in-man pilot study that I'll talk about in a moment, the device received FDA breakthrough device designation and went on to do a pivotal US trial. When discussing the device and its implantation, it's important to review venous anatomy. As you all know, the venous system of the leg includes both superficial veins and deep veins connected by perforator veins. The femoral vein, which is a deep vein, runs in the adductor canal with the femoral artery and branches of the femoral nerve. The canal is subsartorial and extends from the femoral triangle in the groin to the adductor hiatus above the knee. Its borders include the sartorius muscle medially, the adductor longus muscle posteriorly, and the vastus medialis muscle anteriorly. The femoral canal allows expansion of the femoral vein with increased venous return, and the femoral vein is the target of the device implantation. To place the device, the patient is positioned in the frog leg position with the knees slightly flexed and externally rotated, usually with the assistance of a bump. An incision is made along the lateral border of the sartorius muscle and extended depending on the length needed to expose the femoral vein. Careful attention needs to be paid to the superficial vein branches, which can bleed quite extensively due to coexisting venous hypertension as the incision is deepened. The sartorius muscle is reflected medially to expose the neurovascular bundle between the vastus medialis and adductor longus. The fascia is incised over the artery and the nerve, and then the femoral vein is exposed. Femoral artery is skeletonized in order to reflect it off the vein, and approximately 6 centimeters of the vein is exposed with the involved branches suture ligated. Proximal and distal control is obtained. The patient is anticoagulated and a 1.5 centimeter venotomy is made. The valve is inserted cranially with a gentle rotation usually. Ultimately, the bulge of the device should end anteriorly out of the incision with the arrow on the device pointing towards the patient's feet. The venotomy is closed with a running 6-0-proline suture. Early in the SAVI study, there was a small number of bovine pericardial patches used to assist with closure over the device. but as the series progressed, the lack of necessity for these became apparent as patients were selected with adequate venous anatomy to accept the device. The device is then tacked with 4/6-0 sutures placed around the ring on the foot side of the device. The deep tissue is closed and the skin is reapproximated in the normal fashion. These cases took around 45 minutes and weren't particularly stressful. The first in-human study was performed in 11 patients who all had secondary post-thrombotic syndrome. Most had a previous superficial greater saphenous vein ablation and none had outflow issues. Each patient received only one valve and they were on a DOAC for a year at a minimum. The results in the group of patients was profound. It showed decrease in reflux times through 3 years with a 63% average improvement in the reflux. The revised venous clinical severity score showed improvement on average of 64%, and there was more than 80% improvement in pain scores. At 3 years, primary patency was 79%. Due to these results, the pivotal U.S. study was designed. This was a prospective, non-blinded, single-armed, multi-center trial enrolling 75 patients at 21 sites with a goal of assessing the safety and efficacy of the Veno valve for the treatment of patients with deep venous valvular insufficiency. All patients had to be at least CEAP-4B or higher, so they had to have liquid dermatosclerosis or ulcers, or healed ulcers. And all patients had to have deep venous reflux documented on duplex ultrasound. Patients had an average age of 63, were mostly male and white, and most were obese. Importantly, nearly 60% of patients had C6 disease with active ulcerations, and over 70% of those patients had had these ulcerations for more than a year. Patients were followed at 1, 3, 6, and 12 months, and then yearly. Device patency, RVCSS, quality of life, and pain scales were all recorded, as well as ulcer healing. For the latter, the Swift Wound app was used, which uses a camera to determine the size of ulcerations at each visit. The full 1-year results were recently presented at the VEITH meeting. Primary patency at 1 year was 87%, with a secondary patency of 97%. Interestingly, while there were 9 device occlusions in the first year, 8 of these recanalized before the year evaluation. And so the overall device patency was actually 98.4%. There were no procedural related or valve related mortalities in the study group, although 1 patient did die of COVID at 4 months. There was no device related infections, and the average reflux times remained stable at a 1 year post-implant, regardless of the CEAP level. Dr. Dorsey will be presenting on patient outcomes, including quality of life, symptom improvement, and ulcer healing in her talk, but I can say, as a spoiler alert, that these results were pretty promising. So what patients will benefit from Veno valve placement when the device becomes commercially available? First of all, size matters. Femoral veins need to be larger than 8 millimeters at a minimum at the implantation site. And almost as importantly, these veins need to be free of significant post-thrombotic synechia. This post-thrombotic scarring in the femoral vein is sometimes difficult to appreciate by ultrasound and was the cause of 1 failure of implantation in the trial. Secondly, the chronicity of the ulcers may matter. Dr. Dorsey will talk more about this in detail, but patients with ulcer duration of less than a year prior to the study had nearly 100% healing rate at a year, while those with longer durations had less of a response. Finally, hypercoagulable states may be an exclusion criteria. There was 1 patient who had a DVT during the study and who was found to be Leiden 5 heterozygote. Another patient who thrombosed their device was later found out to be Leiden 5 homozygote. Next, venous flow likely matters. These devices, like most things in vascular surgery, need good inflow, good outflow, and a good conduit. Patients with iliac vein obstruction that cannot be opened and those with significant femoral vein occlusion at the site of implantation or proximal to it would not be good candidates. Finally, the presence of large collateral flows may matter. Those patients with robust profunda vessels starting near the popliteal and continuing to the common femoral, and those with significant collateral flow from the popliteal vein may not turn out to benefit significantly from implantation of this device. In conclusion, the SAVI trial has demonstrated good efficacy and safety of the Veno valve device in the treatment of chronic venous insufficiency. Appropriate patient selection may improve outcomes, and further long-term study is necessary to determine long-term benefits within this challenging patient population. Be happy to take questions at the end of the talks, and thanks again for having me.
Great. Matt, thank you very much for your experience with early implantation. Excited to hear Chelsea's speech with all those early spoiler alerts. Our next presenter will be Dr. Lauren Masterson. She'll be presenting on what configuration of venous stenting leads to the best outcomes. Dr. Masterson is the Chief of Vascular Surgery, the Southern Region of Cleveland Clinic in Akron, Ohio. She serves as the Associate Program Director in the General Surgery Residency at Cleveland Akron General. She received her Bachelor's of Science in Chemical Engineering and her MBA from University of Notre Dame, and did her Vascular Surgery Fellowship at The Ohio State. Lauren, I'll turn it over to you.
Matt, you might need to stop sharing your screen for me to share mine. Let's see if I can do that. And I'll get there. Give me a second. There we go. Okay. Does this look okay to everybody?
That looks great.
Yes. Okay. All right. So yes, I'm going to talk about venous stenting. Specifically, I focused on iliofemoral disease because I think this is what most of us are talking about when we talk about venous stenting. I have no disclosures. This is a picture of a patient, kind of a textbook patient picture that we see with May-Thurner syndrome. And I'll talk a little bit more about that. But this is a young, otherwise healthy person, usually somebody who doesn't have a lot of other medical problems or comorbidities, who comes in with sudden onset of left leg swelling. You can see there's a pretty sizable discrepancy in these lower extremities here. Typically, this is diagnosed with a duplex ultrasound. There's some debate in the literature about whether or not you need some sort of cross-sectional imaging before you intervene on these patients, whether that's a CAT scan or an MRI. With a good ultrasound, you can usually get a pretty good image of the external iliac vein. So for most of these patients, we don't get a lot of cross-sectional imaging. We see a young, healthy patient with the left-sided DVT. It's a pretty safe assumption this is going to be May-Thurner's until proven otherwise. Talking about case planning, we'll talk more about venography and IVUS. But when you're prepping this patient for a procedure and sort of getting into the unknown here a little bit, oh, here's a picture of a venography here that shows a pretty good common iliac vein occlusion for this May-Thurner syndrome patient. Just a brief review of May-Thurner. I always throw an extra S in there. It's just May-Thurner. It's not May-Thurners. But May-Thurner. So I also always have to make the little motion with my hands when I describe it. But if you recall, it's the compression of the left common iliac vein by the right common iliac artery. Typically seen in young, healthy female patients. It's more common, smaller pelvises, but it's a pretty common cause of DVTs in these otherwise healthy people. A debate that we have frequently in my own office when we're planning a case is how are we going to position the patient? So prone versus supine is a conversation that we have a lot. There's pros and cons to each. I don't think there's a right answer. I prefer to do my patients prone. I like to have the popliteal access so I can treat further down the leg when I need to. But if you're talking about a patient undergoing conscious sedation as opposed to general anesthesia, this can be an uncomfortable position to put the patient in. Also, if you have a larger patient, sometimes prone is not going to be feasible. If the patient is supine, that's easier for larger patients. It's more comfortable for larger patients. And you have access to the internal jugular vein if you need to get access more proximally for a distal embolization protection device. I know some surgeons who will place the patient prone, get popliteal access, flip the patient over, and then perform the case supine with the sheaths coming up from the back of the leg. And then you can still access the internal jugular if you need to. IVUS is, I think, essential in these cases. I think all of us would agree if you're doing deep venous work without intravascular ultrasound, you're not doing it completely or correctly. This is an image here that shows a venogram that looks pretty good, actually, only about a 30% stenosis, but we all know you get a pancaking of the vein. You're looking at a 2D image of a 3D structure. And if you look at it on IVUS, it's much more impressive. It's 67% stenosed on IVUS as opposed to only 30% from the naked eye on the venogram. So Again, if you're not using IVUS, I don't think you're doing a complete case. There's a good study that shows routine use of IVUS will actually change your treatment plan in more than 50% of cases. We tend to really underestimate the disease in these patients without IVUS. It also showed that routine use of IVUS improves long-term, early and midterm patency rates. Veins stay open longer, that patients have greater quality of life scores following the procedure when IVUS is used routinely. Sometimes with chronically occluded veins, it is difficult to get an accurate size. Here I mentioned that you want to measure the normal adjacent vein. Sometimes these patients don't have normal adjacent veins. So a kind of a good rule of thumb is the 16-14-12 rule. That's what I was taught. 16 is a common size for a common iliac vein, 14 for external, 12 for femoral. In smaller patients, particularly smaller women, you might want to consider 14, 12, 10 instead. But those are good numbers to have in your head when you're planning these cases in case they don't have normal vein to judge against. Venous stenting, there's been a few studies that have looked at angioplasty versus angioplasty plus stenting. The stenting results are always more effective. Angioplasty alone is not effective long-term. These patients need a durable device. There are currently 4 FDA-approved venous stents available. The 2 I've blacked out here were only available in Europe. As you can tell, graphic design is my passion. The wall stent, the Zilver, the Abre, and the Venovo stent are the stents available in the United States that are FDA approved. The wall stent is closed cell. The others are all open cell. They're all self-expanding stents. There is no difference between these stents and long-term outcomes. So whatever whether it's closed cell, open cell, or whichever company makes it, they all have the same long-term outcomes. Whichever stent is available is generally the stent that you'll choose. When talking about stenting, especially in these chronically occluded veins, predilation is important. It's recommended to predilate to the ideal stent size. And then stent placement, you're going to estimate size based on IVUS, or if it's a chronically occluded vein, you can always look at your standard sizing charts. You want to overlap at least 2 centimeters if using multiple. Post dilation is also frequently important, and then you always want to do a completion IVUS and venogram to verify your results. This picture, I think, is a good picture of the landmarks you should be looking at for the best stent placement. Your cranial landmark is going to be the confluence of the iliac vein. That typically lines up with the spinous process. This is an example from an Endovascular Today article of showing improperly placed stents. The stent should really cross the midline if this is a patient who is prone. So we're looking at a left-sided stent. So the stent should cross midline. We'll talk a little bit more about that in a second. The outer edge of the spinal body is your contralateral IVC wall. So in between those spots is kind of the place to land your proximal stent. You can land as far distal as the lesser trochanter, but after that, you're going to risk jailing out your profunda vein. So you don't want to go much more distal to your lesser trochanter, and then you want to cross the midline, but not quite cross over the spine of the body on the top. And I think there's a stent fracture in there too, if you look closely. When talking about May-Thurner specifically, there is a May-Thurner pinch point, also called the Crockett point, the point where the artery does sit on the vein. That is very near the confluence of the iliac veins. And that's why it's recommended that you extend far enough into the cava that you achieve good overlap of the compression. If you're trying to just keep it within that left iliac vein, you're probably not going to get enough overlap for it to go into to appropriately treat that area of compression. When we're talking distal, if we go past that lesser trochanter, there's an increased risk in several studies that there's a higher risk of stent fracture. They looked at stents that go past the inguinal ligament or past the lesser trochanter on plain film, and they have a higher risk of stent fracture at that point. When looking at your overlap, you want your overlap to be somewhere, usually in the external vein, if you're placing multiple stents and you're overlapping, because that's the most limited movement vein. You're not going to have as much risk of stent fracture in that area. This is a case I wanted to show that is a case that actually one of my partners did a couple weeks ago. This was a 31-year-old male who presented to us with a large right-sided proximal DVT. He's a young, healthy guy. He's a truck driver, sits all day, every day. And he presented initially to the emergency department with his right leg swelling, was diagnosed with a DVT. Pain and did not improve. After a couple of days, saw his PCP, who called us to have him seen. This is his ultrasound from the emergency department. This was about a week before we saw him. You can see he has a completely occluded external iliac vein. There's absolutely no compression. You can kind of get a sense on this image that there might be a little bit more chronicity to the DVT than we originally thought. He had only had pain for about a week, but if you look at the ultrasound, you can see it's a little brighter, it's a little more hyperechoic, so it's maybe a little bit more chronic than we thought. Spoiler alert, it totally was. So this is, my partner took him in. This was performed prone. This is the initial venogram from the popliteal axis, and you can see there's collaterals. There's a complete occlusion of his common femoral, of his external and internal iliac vein on that right side. So this is significantly more chronic than just the week of symptoms that the patient has had. That's something that we come across frequently when we're seeing these patients, is they may have only had symptoms for a couple of days, but we find it's much more chronic when we get in there. After a couple of hours, and bless his soul, he got across it. He got across everything into the cava. This is the IVUS here, where you can see it's almost completely collapsed. When he was doing the IVUS and coming up into the cava, he noticed that there was thrombus extending from the left side into the cava as well. So he got access to the left side. And this is a picture of the left side, where you can see the common iliac vein there is completely occluded. That's the artery on top. So he had a significant May Thurner's that was undiagnosed, that led likely to the DVT on the right side as well. This is then access from the left side. This is up in the pelvis. You can see, again, he's got significant collaterals, complete occlusion of that left common iliac vein. He did a thrombectomy at this point. You can see the thrombectomy device here. This did show good resolution of the clot in the leg, but there was still significant blockages up in the pelvis. I don't have a great picture of when he was putting these stents in, but I wanted to show this image of one of his completion films. So again, both common iliac veins were completely occluded. The external iliac vein was occluded on the patient's right, and it went down into the femoral vein there. He did place 16 millimeter stents up in the common iliac vein. He had to place kissing vein stents, which is not very common, but with a complete occlusion, you have to rebuild the cava up a little bit, and that's what he did there. Sorry, excuse me. And you can see here, so there's spinous process. Remember, this patient is prone in this picture. So the spinous process, and then you can see the outer wall of the cava lining up with the spinal body there. So this was a complicated case, took several hours. The patient's been seen in clinic since then. His symptoms have almost completely resolved. He's had follow-up ultrasounds that show that his cava is patent, his external iliac stents are patent, and he's back to work and he's doing great. But just a couple of take-home points here. Venography and IVUS is essential to good case planning. Again, I can't reiterate enough, if you're not using intravascular ultrasound, I don't think you're doing a complete study. Iliac stenting across the midline is needed to adequately treat the proximal compression, and you can extend to the confluence of the deep femoral vein. So those are just some little points we've learned. I'll take any questions at the end.
Thanks so much, Lauren. That was great. A really great discussion of what I think is a difficult process to take care of, and sometimes a little bit under-recognized for the challenging pathology that it is. Our next speaker is Dr. Chelsea Dorsey. Chelsea is one of my partners here at the University of Chicago, where she's an associate professor of surgery. She also is an associate dean for the Pritzker School of Medicine, as well as a vice chair in our Department of Surgery. She did her medical school here at University of Chicago, and then her integrated vascular surgery residency at Stanford, after which she returned to us. Chelsea is an expert in the treatment of venous disease, and today is going to share with us patient-reported outcomes from the ATTRACT and SAVI trial. Are we making any progress?
Awesome. Thanks for that intro, Trissa, and thanks to MVSS for the opportunity to present. As Trissa stated, I'm going to try to focus specifically on patient-reported outcomes on some of these most recent trials here. I did serve as a PI for the SAVI clinical trial at the University of Chicago, and I do have a couple slides from enVVeno at the end of the talk. So I'm not going to spend a lot of time here. Simon actually did a really nice job of kind of talking about the prevalence of chronic venous insufficiency. I want to talk specifically a little bit about the sequelae of patients who have acute DVTs. This happens in about 20 to 50% of patients who get DVT. And obviously, we know these patients as individuals have really chronic, persistent pain, swelling, skin changes. But I think one of the aspects that we actually don't talk about a lot is the impact to their quality of life. I'm often sitting across from these patients, and they really aren't able to often do the things that they want to do on a regular basis. And there's been a little bit of work in this area, but I think there's probably significant opportunity for us to learn more. This is a study that was published in 2023 in the Journal of Thrombosis and Hemostasis that specifically looked at patients with acute VTE, and then really looking at their increased risk of depression, which I think is an important point here. As Matt talked about a little bit, these really beautiful surgical procedures have been done more so in the past, including valvuloplasty, femoral transpositions, vein transplants, but we really don't have a lot of experts that are doing this on a regular basis. And as he touched upon, the outcomes in these types of procedures, it really wasn't clear if the patients were getting benefit. And of course, now we're kind of in a phase where most people aren't getting training related to these procedures. And there are very few places of clinical excellence that are doing this well. And so as almost all of the presenters have stated, it's frustrating, I think, as a provider, because we are often seeing these patients and we don't have a lot to offer them. We're left with leg elevation, providing them with compression stockings and 4-layer compression wraps in the case of venous stasis ulcers. And I think those patients are the ones that are the most frustrating, and they come in and they've had chronic wounds for 6 months, a year, 2 years, and again, not much to offer them. But that has changed a little bit here. The landscape has changed in the last couple of years. So again, I was asked to talk specifically about patient-reported outcomes. So we'll go quickly through the ATTRACT trial, and then we'll move on to the SAVI trial. So the initial data was published in the New England Journal of Medicine back in 2017. This was nearly 700 patients that were randomized to 2 groups. The control group was just anticoagulation, and then the other group included anticoagulation along with pharmacomechanical thrombolysis. So this was given to patients with acute proximal DVTs. And interestingly, the conclusion here was that actually doing pharmacomechanical thrombolysis, when you look at this larger group of almost 700 patients, didn't result in a lower risk of post-thrombotic syndrome. So we'll look a little closer here. But you could start to see a significance as we were thinking through patients with moderate to severe PTS. And of course, those receiving pharmacomechanical thrombolysis had an increased bleeding risk as well. But if you start to delve into the data a little bit and you're looking at these kind of clinical severity scores, you can see that the patients that had the intervention had improvement in these scores, including the VCSS. I think what was really helpful was the subsequent studies that were published that looked at the kind of smaller groups. So this was in Circulation, I think in 2019. So this specifically looked at individuals who had acute DVTs in the iliofemoral segment. And again, those two groups, the control versus the pharmacomechanical thrombolysis. And you can see this is where you can actually start to understand that patients are having an improvement, both in just leg pain, but also in reducing the proportion of patients who develop moderate or severe post-thrombotic syndrome, and that the improvement in the quality of life indicators as well. There was a nice study that was published in JVSVL, also using that same ATTRACT data, and really dug into the details of the quality of life indicators, and showing that if you compare the iliofemoral DVT patients versus the proximal DVT patients, again, you're seeing the significant improvement in disease-specific quality of life more in the long term, so over 24 months. For the proximal DVT, you saw improvement just in the short term over 6 months. So moving over to the SAVVY trial, as I said, I was a site PI at the University of Chicago. It was really fun participating in this trial. As Matt stated, it's a relatively straightforward procedure and easy to implant these devices. I'm going to skip over kind of the demographics and the data that Matt already presented, and specifically focus on the patient-reported outcomes. So clinical meaningful benefit is actually really important to the FDA, and this device is currently in the latter stages of that process. What was exciting to see is that the vast majority of patients, 85% of the patients, saw a clinical meaningful benefit, so a greater than 3-point improvement in their RVCSS score. So that was 55 patients of the 65 that we had long-term data on. Of that group of 55 patients, on average, we saw an 8-point increase in their RVCSS score, which is pretty amazing. And then if you're thinking about the patients who didn't see improvement or worsened, it was a really small group. So only 2 out of those patients had worsening in their symptoms, and only 3 with no change at all. Oops, going the wrong way. And then for the leg pain scale, also 75% saw an improvement in the average VAS at 12 months, so that's 61 patients. And this is really what floored me. And again, Matt started to talk about this a little bit, but the fact that patients with ulcers saw such significant improvement, these were all C4B or higher patients, but those with ulcers. So again, let's break this up into the 2 categories. So patients with ulcers less than 1 year, all of them saw some degree of improvement, and the vast majority of those patients fully healed their wounds after having the Veno valve implant. Now, it does appear that the group of patients who had ulcer duration of greater than 1 year, it seems like a kind of different batch of patients. They still saw significant improvement, and about a third of those fully healed their wounds. But I think we could all agree, when we see those patients in clinic, there's often other things going on, other comorbid conditions that are contributing to what's going on. And then also really nice to see that these quality of life indicators for the patients, all of them improved across the board. So this is just a summary of what I basically just stated. What's exciting to know as well, and I can't remember if Matt had mentioned it, but we have this surgical implant now, and again, it's at the final stages of the FDA approval, and now they're looking to move forward with a percutaneous device too, and I'm really excited to see that, because I think that'll be very helpful for some of our older patients who don't want to undergo these larger surgical interventions. So in the end, deep venous insufficiency, chronic condition, many of which have post-thrombotic syndrome. It's been sad over the course of the last several decades. We've had very limited treatment options. And I think a lot of those patients deal with issues related to depression and poor scores on quality of life scales. But hopefully this is an exciting time in venous care with some additional devices in development. I'm happy to take questions. Hopefully I've left maybe a minute or two.
Well, Chelsea, and hopefully, we can go a little bit longer here because there's a couple, just to bring attention to the Q&A box. So there's a couple questions that have already been answered. If we have time, we'll go over it. Chelsea, a great talk. There are 2 unanswered questions. And before we start, I just want to ask one, maybe of Matt and Chelsea, is, I remember when we were searching superficial venous reflux, right, ablation, and what a difference that made. And clearly we're left with this enigma of deep reflux with really bad quality of life indicators, right? Patients are in and out of the hospital, recurrent admissions, debridement, cellulitis. What is the option for reintervention for those valves that thrombosed? Obviously 9, and you're limited by size on biologic material and necessary flow volumes, but what was offered to those patients, and did they just recanalize with anticoagulation, or what's the future of that?
I can answer that question, or I can start the answers to that question. I actually had two patients that thrombosed their valves, and one I thought maybe I would try to do penumbra, so I sucked it out and I got it open, and then I think a month later it reoccluded, and I was like, oh well, I guess that's it for that thing. But then a month or 2 after that, we brought her back just for the standard follow-up, and she had recanalized the valve, and she had decreased reflux below the valve, and she had ulcers that were healing. And so, I don't know if it was related to me doing penumbra on it, or if it would have recanalized anyways, but there was still some effect seemingly from doing that. Then I had the other patient that thrombosed, I didn't do a penumbra on, for a long story reason, but and she ended up recanalizing hers as well, and also healing her ulcers. So I think that time will tell what you need to do and what we should be doing to reintervene, but a lot of these things kind of opened up on their own. It's almost like the natural history of a DVT, I think, where you get some recanalization. Because like I said, there were technically 9 patients that occluded their device at some point within the first year, but 8 of those recanalized. And a lot of those, got benefit despite having that occlusion.
I'm sure the risk of, or the rates of thrombophilia in this patient population, Matt, is higher than the general, right? So I'm sure it's going to be.
I don't know. It's hard to say. One of the patients was that got a DVT was found to be Leiden 5, and then one of the patients who thrombosed their device was found to be Leiden 5, and so maybe those patients we shouldn't be enrolling. Shouldn't be putting these devices in that have known disease processes. So that's time will tell. We're working with a real small number of patients right now, so we need some real world data once the device gets released and go from there.
I was just gonna add, I agree with everything Matt said. There was the question in the chat specifically about like who do we offer this to? The one thing I felt like a little uncomfortable about was someone who honestly didn't have post-thrombotic syndrome and wasn't on anticoagulation already and was younger. I just, because as soon as we put the implant in, they need anticoagulation. That's probably going to be something that's long-term. So I think that's something that we have to think about. I thought it was interesting that so many of the ones that thrombosed recanalized, like to the point where I was like, should we not even intervene if this happens on a patient that we put it in? But I think, at least in my conversations with the company, it sounds like, I think at least in that acute phase and the immediate phase after the procedure, I think it's worthwhile to try to salvage.
Yeah, it's interesting because I agree. I felt really, I was really trepidatious about offering the device for a very young person who wasn't on anticoagulation, but almost across the board, I would talk about the device and everybody was like, I don't care. I'm suffering from this disease and I want to have something done. I don't care if I'm taking anticoagulation, because I kind of went into it with the assumption that I was probably going to want to be leaving these people on anticoagulation lifelong, even though the trial was technically just for the first year. I think everybody in the trial stayed on anticoagulation, a DOAC, after the year. All my patients did. I know that for a fact. But so it'll be interesting to see how real world data works out.
Great. I think we have time. We'll make time for maybe one more question. This one, Lauren, is for you. It's about how do you determine how you're going to size when you have such disparate measurements? If you have a proximal vein that looks like it's about the size of the cava and distally it's, a couple millimeters, how do you make that determination and where do you draw that line? You don't want to have a stent that occludes. You don't want to have something that's free floating proximally. And how do you really determine that? And is there a role for multiple stents and stacking? And how do you think about all of that?
I use the 16, 14, 12 as kind of a size guideline for completely occluded vessels. It's much more dangerous to undersize than it is to oversize. Because undersize, you run the risk of it flying off, and then next thing you know, it's up in the heart. And oversizing has been shown to be safer. So if it's completely occluded, I will use, as a general rule, 16, 14, 12. I've gone as low as a 10 in a femoral for a smaller person. But in general, I think that's a safe choice, and you want to build up into the cava up until a patent area of the cava. If that means kissing iliac vein stents, it does, but you want to build up into patency and have it go down into patency without going past that lesser trochanter. But that's kind of my general rule of thumb when they're completely occluded.
Great. Well, I want to thank all of our speakers tonight for a really engaging, really exciting topic. You made all of these topics really interesting to listen to, and we all learned something. I'd like to thank Mike for being my co-moderator tonight. And I'd also like to thank the Society for continuing to really prioritize these New Horizon events. They're really a great learning opportunity for us, and as well as enVVeno for their very generous support, which our industry partners allow us to do things like this. So I hope everybody has a great rest of your evening. And thanks again, especially to the audience, for joining us.